So good afternoon, everybody. Again, this is John Lee with Coordinated Care Services, and welcome to today's Performance Driven Academy webinar. And this is session 5, given it's the month of May, and our focus today in terms of developing the skills and capacity to become a performance-driven organization is going to focus on continuous quality improvement practices. So just a reminder that the Performance Driven Academy is brought to you by the Managed Care Technical Assistance Center, and CCSI is the upstate New York partner. And don't forget other very, very important partners. In fact, those that lead this initiative are the McSilver Institute for Poverty and Policy Research, as well as CASA, the National Center on Addictions and Substance Abuse. Again, John Lee, I am the Director of the Center for Collaboration and Community Health at CCSI. So just a few reminders as we do at the beginning of all of these webinars. Make sure that everyone in your work group registers for the at least one of the June in-person sessions, and certainly one will be enough, but remember these are the opportunities for us to work in person and review the materials that have been covered in April, May, and June. Actually, it'll be April and 2 webinars in May, but it's the opportunity to really work together on those topics that were covered and get feedback from those that presented. And don't forget, if you're joining us for the first time, as we said earlier, complete the baseline survey. The link is found in the chat box. And please review the webinars 1 through 4 on the MCTAC website. We think that those will be really helpful to orient you to the work of the Performance Driven Academy, especially the work that has been done in the first part of the year. Don't forget the webinars are recorded, and you should have received the materials ahead of the webinar. Use PDA@ccsi.org to email any questions or comments that you have now or later. And if you have a question while your speaker is chatting today, chat the questions in the chat box. And although we won't respond to those right away, at the end of the session, if we have some time, we will definitely give some thought to your questions. So what is the Performance Driven Academy? The goal of the Performance Driven Academy is really to provide agencies with information to support the development of the right culture, practices, and infrastructure to make sure that as you move forward in this world of value-based payment and across the board greater accountability, you have the tools and the wherewithal to really track the impact of your service and continuously improve, and do it in a developmentally appropriate way. You've seen this graphic before. It really shares with you the elements that we believe are critically important to become a performance-driven organization, starting with that culture in the dark blue, a set of practices and processes that are in a pale yellow, the infrastructure elements that will support those practices, and importantly, the notion of collaboration, both internally, others within your agency, as well as those that collaboration that will support network development, improvement, and outcomes. Today's focus, as we said, is on continuous quality improvement. So we hope that with active participation in the Performance Driven Academy, your agency will really be positioned to know your costs, your quality, and overall the impact of your services within the broader system of care, and to be able to communicate that to others. It can help you generate a work plan to really integrate the knowledge that's gained to build those capacities within your organization. We continue to focus on providing you with tools and other resources to help you work with others within your organization to begin to build the structures, the processes, the belief system that's going to allow you to succeed in this. We're hoping that through this process you can better document your growth and improvement. And we will be tracking that as well in the evaluation that you complete. But so important is that using these tools, developing this culture can really help your agencies demonstrate a commitment to becoming a performance-driven organization, or an organization that is focused on making sure the resources within your organization are being used to provide the best possible outcomes for those that you serve. Very, very important. And when you get through with this, you will receive a certificate of completion. That's not a great reason for participating, but it is a demonstration of completion. So a little bit of conversation about where we've been. Those that have participated probably will recall this. We began by talking about the elements of a culture that will support the development of the performance-driven processes. That's a belief in wanting to know how well you do and being able to commit to making changes to continuously improve. We talked about collaboration, both within the organization and outside, needing to work with others to make sure you're using your resources wisely to demonstrate the best impact. We talked about best practices in human resources. That's where your investment really is, and your team, your staff really needs to be in line with these expectations. But we can't just say, hey, we're going to become performance-driven and expect that that'll happen. We need to build an understanding with the staff so they can understand how important this work really is to them and to the individuals that you serve. And last month, in April, we began to talk about developing effective measurement practices so that you can think about what you should be measuring and build the capacity to do that using valid and reliable data. So since we're in the second quarter of the year, these are the 3 areas of focus for this quarter. Effective measurement, that was in April. Continuous quality improvement today. Practice development will take place at the end of May, and then in June, as we said, we have in-person sessions scheduled in Rochester, Albany, and New York City. Important times for you not only to work with your own team, but others to really begin to apply the information that you're learning. And then we're going to move into semester 2 in July, which focuses on finance and leadership.
Yeah, it's frozen. That's what I see.
Yeah, give us a moment, and we appear to be happy. So we're having just a little bit of a technical difficulty in advancing the slides in the PowerPoint, so if you bear with us, we'll get back to you as quickly as possible. Thank you.
Don't want to close that.
All right, our apologies, but for some reason our WebEx system is not being responsive. So what we're going to need to do is have everybody shut down. Can they stay on the phone? You can stay on the phone.
I don't know.
How's that? But we really need you to shut down.
We're going to shut down. So everything is going to close out, and then we're going to try to just restart this from scratch. So you probably will need to hit your link again to re-enter. I'm not sure if you'll need to call back in or not. We're really sorry about this, and I'm not sure why.
But we will do that and
be back in a little bit.
Give everybody a little bit of time to work through the process, and we'll keep you posted.
Hey everybody, we are back in business here, continually trying to improve our WebEx link here. Please let us know through the chat box if you are able to see the screen. You should be seeing something that reads Continuous Quality Improvement Practices, the Performance-Driven Academy. So please give us a quick indication. Okay, looks like we're thumbs up. Again, we apologize for that. Something related to our internet connection beyond our control. And those things do happen with a continuous quality improvement practices, but we will forge on. So this is webinar number 5 of the series, as John Lee was saying here. So what we're going to do is I'm going to introduce myself here since John went to problem solve. I'm a licensed mental health counselor. My name is David Eckert, by the way. I've had the pleasure of working here at CCSI for the past 10 years. And in my background, I've been a clinic manager. I have expertise in behavioral health clinic design, clinical documentation, open access, collaborative documentation, and CQI efforts that support effective practice across all behavioral health different programs and services. Again, here at CCSI, I'm a senior consultant, and I have the pleasure of working with behavioral health providers in networks and different counties, et cetera, across upstate New York, and helping us get ready for managed care, value-based payment readiness, and all of that's driven by improved outcomes. So I'm able to do a lot of this work with a lot of great people. We are joined today by Andrea McIntyre. She is the Compliance Quality Assurance Officer at Chenango County Mental Hygiene Services. I've had the pleasure of working with Andrea for the past 2 years. She has oversight of the compliance and continuous quality improvement efforts for Chenango County, and they operate outpatient mental health programs for adults and children, including satellite clinics in schools, and they also have an outpatient substance abuse clinic. So they do a lot of great integrated care there. And again, we've been working with them for the past couple of years, and Andrea will offer her perspective on what CQI has been like right from the agency perspective. So continuing here, today's learning objectives, what we hope to accomplish. We're going to try to cover a very rich topic. When you're talking about continuous quality improvement, there are entire semester courses on the topic. You could get degrees and degrees and certificates in the topic. So we're going to be scratching the surface but covering some very important essential elements of it in this hour. We're going to talk about the importance of consistent workflows, processes, follow-through, etc. All of those unglamorous things that really make it work, very essential things. We're going to talk about how it's applied at the agency, program, and network levels. We'll talk about high-profile measures that are getting a lot of attention across New York State. So when we're directing CQI efforts and we're talking about what we measure, we'll talk about very common measures that are being used out there these days. Again, we'll be very agency-specific, checking in with Andrea at Chenango to show specific examples of CQI in action. We'll talk about the tools and resources that support data collection and reporting, and how these reports are utilized, again, to support effective CQI practice. So what is continuous quality improvement? Here's the definition. A definition: CQI is the process by which organizations objectively, systematically, and continuously assess, assure, monitor, evaluate, and improve the quality of programs and services provided to their clients. This requires establishing program-specific goals, objectives, and measures, known as performance indicators, and includes training staff and CQI methods and tools. Everybody's involved in CQI. It often utilizes the plan, do, study, act approach, which we'll be highlighting as we talk about today's examples. The other piece here is, what is CQI really? So beyond the definition, what happens in real life when we're applying CQI? It's the philosophy that focuses on improving systems and processes of an organization. I guarantee you that the organizations, businesses, places that you take pleasure in shopping at or being a part of use a continuous quality improvement process. It's the curiosity that always asks, how are we doing? How do we know how we're doing? How are we measuring it? How do we do better? And it uses very specific methodology. Again, it's objective. It's not an emotional process. It's what the data tells us. It's data-driven, and it's cyclical. It is always striving for making things better. It's not a judgmental approach, and it doesn't mean the way we're currently doing things is somehow bad or wrong. It doesn't mean that at all. There's not a right way and a wrong way, but what it says is there a better way? Is there a way we can improve on what we're doing today to have a better tomorrow? But how do we get people involved in it? So why CQI? It helps organizations become better at improving the lives of those they serve, finding efficiencies, enhancing staff efforts, and well-being. So really everybody wins when it's going well. It is the foundation of a performance-driven culture, so it really is central to the performance-driven academy work that's happening here, or an important facet of it among the other important facets. It facilitates alignment with state and federal policy goals. The measures we're going to talk about and highlight today have been put forth by the states, and again, they're high profile for a reason. When we do better at those things, everybody does better. Health improves. And relating back to the triple aim, this is something from the Affordable Care Act, otherwise known as Obamacare. It's a central component of New York's Medicaid redesign team that we want to improve the quality of care, reduce costs, and improve our overall population health. So all those three things at once in motion. And to get people involved, we really want to start with why. Why do we want to do CQI? Again, we want to begin this conversation by avoiding judgment, avoiding that there's somehow something wrong with what we are doing. So we need to help people appreciate why improvement is needed to help them become engaged in the process. We need to align what we want to improve with their own values, with why they show up to work and why they do the work that they do. It's not some measurement that hangs in the air somewhere. It's central to why people come in to use the service and how that can improve. Leadership, it's important to note, who have more exposure to the data and reports, et cetera, and live in that world more often than the direct care staff, have had more time to adjust to change and should understand that others need time to adjust to change as well. Change can often be perceived as threatening even when it's a positive change. So really appreciating that people need time to embrace it, to adjust to it, to start with the why of why we want to improve this thing, and then how we plan to improve it, and communicate. Really give important information back to folks about how it's working. What are the measurable results? What are the qualitative results? What are people saying about the change? Are we communicating it back to them? So when everybody's working hard at things, they need to know that there is a benefit to it. So we're going to chime in with Andrea in Chenango here, who again has been actively involved in CQI for a couple of years. Andrea, how have you worked with your administrative support staff, clinicians, clients, et cetera, in getting them involved in the why of the CQI processes that you've been doing there in Chenango County?
Well, I think framing the why is the most important thing, and it's kind of been the biggest challenge for us to help our staff to understand the reasons for the change and, you know, how it will help us be more efficient and effective in delivering our services and doing the work that we do best. And especially in a managed care, value-based environment, and to remain fiscally viable, these are very important things. But even more importantly than that is to help them understand changes actually improve the care for our clients. And I think especially for our clinical staff, that's where their buy-in really comes in, because that's what they really care about most, and they're overwhelmed with work. So if they believe that the changes that we make actually allow them to provide better care, I think that they were going to have much better buy-in to that change. Quite honestly, having CCSI come into our agency and frame that why, has been very helpful, because hearing, the big picture and where we need to go in the future, and hearing it from somebody outside the agency has, I really believe, helped us to move forward in this process.
Thank you, and it's a pleasure to work with you, and I appreciate that, and it really does come to staff embracing the change. It's hard to move forward without that legitimate buy-in, without them really appreciating, hey, it's going to pay off. It's for quality care. So the cycle that we go into, that we're always talking about the rapid cycle improvement process, and it is Plan, Do, Study, Act. Interestingly, it used to be Plan, Do, Check, Act, but early on it was determined that just checking the results, we really want an analysis of the results. So most frequently now it's referred to as the PDSA cycle. So let's talk a little bit about that cycle, the Plan, Do, Study, Act cycle. In Chenango, we're working on it to improve show rates. That's one of the many efforts that are underway there in the CQI world. So across behavioral health systems and levels of care, improving attendance at scheduled appointments is a common goal. Everything gets better when people show up for their appointments. We can apply the use of the Plan, Do, Study, Act approach to be more consistent in this goal. We ask ourselves that question. What can we do with this approach to help improve show rates? And it becomes a win-win initiative. Again, when people are attending more consistently, this improves the quality of their care. It increases clinical consistency, so you don't feel like you're starting over again in some ways. You can pick up where you left off with them, again, across all levels of care. And it also, of course, will improve financial performance, which is an important consideration in today's environment. However, improving show rates isn't the only measure. We talked about high-profile New York State measures. Others include the DSRIP effort to reduce the use of acute services by 25%. So focusing on the reduction of ER visits, hospitalizations, and those rehospitalizations within 30 days, that's another real win-win for everybody when we're addressing those needs at lower levels of care. And then the links between levels of care. We really want to build those bridges and have successful transitions and client engagement from inpatient to outpatient settings. Avoid that churning process that doesn't help clients and certainly doesn't help us. So engaging clients as they're transitioning from levels of care, very important thing to measure, high profile. Access, regardless of the service that you're providing, we want to be able to get people into care. So that time from the first call to the initial appointment is important here. So looking at how much time does it take from that call to the first appointment. And then once we do get them in, consistent attendance early in treatment. So just getting them in the door at whatever level of care we're talking about, great, but are they staying? Are they sticking? Are we engaging them? Because we can't move toward great outcomes if we haven't really engaged with them. Medication adherence, very high profile across the state for a reason. We see, especially this relates to the use of acute services quite often, et cetera. And the need to stay on medication once folks are on medication, and those that are the focus currently, not meant to be an exhaustive list by any means, but keeping children on ADHD medications, antidepressant adherence, antipsychotic adherence, et cetera. Folks do better when they're consistent with their medications. And then we have symptom and functioning measures. Just a couple of real quick examples here because there are multitudes of these. The Patient Health Questionnaire 9 and the Daily Living Activities 20, the DLA 20, really measure symptoms and functioning. And of course, we want to know what clients say about how we're doing, and client satisfaction surveys remain very important. So not an exhaustive list, but other examples of high-profile measures here. So how to begin using the PDSA approach? We need to decide who's in the work group. We've talked about the buy-in. We want them involved early on because they really see things up close and personal. Much of CQI started at auto assembly lines when they wanted to know from the people on the assembly line, how do we improve our production of these cars? Let's talk to the people involved with the direct building of them. Well, of course, we're not dealing with cars, but we are really valuing the input of those that have direct service delivery and the administrative support staff, et cetera. We really want to know what they think because they have great essential information about our workflows, processes, goals, targets, et cetera. And then leadership has the authority to make decisions on these findings and ensure implementation of the do, of what we're doing about it. So it's important to take things one step at a time. Often we can get too aggressive. We can set goals that are too expansive. And we can't chase in three directions effectively at one time. So having focused areas by program really makes a lot of sense. And then timelines. We recommend short cycles and really looking at time to see what the data tells you for rapid decision making. Now, the real world may not work that perfectly all the time, but we're setting a standard here talking about getting people's input, leadership making the decision, getting data out there, and really reviewing it on a regular basis. So checking back in with Andrea here, in your own PDSA processes, how have you worked with your support and clinical staff to get their input in the planning process and deciding where to begin and in establishing timeframes? How did this work for you guys in Chenango?
Well, you know, just to go back a little bit, historically, I can tell you how our CQI process worked, and the C was for continuous, which was usually continuous planning, and we would get stuck in those efforts of trying to make a plan that was perfect right from the get-go, and it never works that way. So really, we make a plan. For instance, we have recently, well, it's been over a year now, implemented our open access process. So we make a plan, so we plan as best as we can, try to think of as many things as we can. We put the plan into place, and then we check to see if it's working, or study to see if it's working. And then oftentimes there's pretty quick turnover revising that plan with the things that we've noticed that maybe are not working. And that can be a difficult process for the staff because they get frustrated because I think they think that the plan should be perfect right from the get-go, and they might think that the leadership is inept or, that they can't get it right the first time. So that's been a real culture change over time. But we have gotten the stakeholders involved, meaning the support staff, the clinical staff, senior staff, and get their input. And because they're the ones who do the work, they often know best what areas and how things are going to work most efficiently. So we've seen this work in our open access program, and it's worked terrific. It's solved a lot of other problems we've had helped us reduce our no-show rate, but we can probably talk more about that later.
No, excellent. And I love what you said about the culture change too and starting somewhere. That's such an important theme. It's so hard to consider everything and wait, or collect more data before we get started. It's about taking action with what you know and the data you have. So I think that's excellent input. So talking more about the planning part of the cycle. General considerations. What are we going to do with PDSA? What is the question we're trying to answer? What is the goal? Are we taking the necessary steps to help clients attend appointments consistently? We ask ourselves those questions. And have we achieved targeted improvements and show rates for our scheduled appointments? So talking about this, and an important piece is operationalizing that data. So when we're talking about what we're studying here and getting our definitions correct so that everyone's talking about the same thing, I know in Chenango we talked a lot about what does a no-show mean in particular? What is a cancellation? What's the difference there? What does staff canceled mean? So Andrea, can you say a little bit about the detail-oriented part of the planning process and operationalizing those definitions related to show rates?
Yes, and we did operationalize those terms quite a long time ago. The problem is that sometimes that it's not followed through with and it's not looked at carefully enough so that things kind of fall to the wayside. But we have things operationalized, and for our show rate in particular, we've implemented a client attendance policy that we need to and continually review with our staff to be sure that they're holding the clients to the same expectations that we're expecting. We provide data to our leadership with no-show rates by clinician, by program, and by client, so that you can look at the areas that, kind of drill down on the areas to see, okay, what's going on here? So the data, one of the, I think, frustrating things, and it certainly is getting better in time, is that the data gets provided, but people kind of put it in the drawer and don't look at it to say, what can this data tell us that can improve our performance, improve our services, improve our outcomes? So we really have operationalized lots of processes, lots of procedures, and one thing I've learned is you have to continually review because you get new staff, you think a process is being done, and it might not be. It might have fallen to the wayside. So you really have to continually go back to look at to see that these things are being done.
Excellent. It is all about follow-through and that level of persistence. Excellent description there. Thank you. So talking about the planning process, this slide just breaks down planning itself. So the brainstorming to determine the impact of what you've done, connecting that impact to goals and to a logic model. What are your opportunities for improvement? What does the data tell you about where you should start? Is that data easily identifiable? Is it easily available? Again, we want actionable data. And the questions we get into, or the conversations we get into are always, yeah, but what about this data, this data, this data? Well, you could end up going down a wormhole with an endless search for more data when you have data in front of you that says we should be taking action on this thing. So the question of, what's the question? Identity, outcome of focus, meaning what does that destination look like? What are the targets associated with it? Selecting the data and the method, balancing resource and availability. Efficiencies here are important, and again, in the data retrieval process. And then you set up your targets, create your measure, operationalize your variables so that everybody's sharing the same language and we're talking about the same things. It takes a little bit of time to get everyone on that same page. And the CQI process to review data. Again, did we answer the question? Does it relate back to what we originally set out to measure and to improve here? So this talks about the planning process and how that is cyclical as well. So more about planning and details. Who will enact the PDSA cycle? Who are those responsible people? What data points are needed? Who will collect it? How will it be collected? Who will be aggregating and analyzing it? And when will we reconvene to look at it? With what frequency will we keep meeting? As Andrea was saying, we've got to stay on top of this, so let's plan this. It's not a thing that will go away. It's what we're looking at now because we're serious about making this change. So looking at that cycle of meetings. So specific to the show rate project, it was piloted in the outpatient mental health clinic. Identified staff person responsible for generating the reports. It identified essential data sources and data points pulled from Acumed, the electronic medical record. Now that in and of itself was a lot of work went into it. What are the data points? How do we find them? How do we retrieve them consistently so the data is valid? Identifying those different appointment types, making sure they're getting entered into the system accurately. What does an attended appointment mean? Canceled with notice. Within what time frame? Canceled by clinician. What does that mean in terms of did support staff cancel it, et cetera? Let's look at what that means in particular. And what is a no-show, no-call? What's the time frame that represents a no-show? And then giving reports back, as Andrea said, by clinician, by job type, and for the whole clinic, that we give comprehensive reports back that show how do we look at each clinician, for the nursing staff, for the prescribers, the medical staff, for the clinical staff, what are the show rates there, and then what are the aggregate rates for the whole clinic using this example. And from that, we were able to get a plan for data collection and reporting. So the tools that we utilized for this are the electronic medical record system, in this case Acumed. Need to ensure we got the right points. We operationalize those definitions. Then we put the data into Excel so it's very workable. It was pulled in CSV files, formatted in Excel, and we wanted to make sure everybody's doing it the same way because we want, obviously you don't have valid or reliable data if people are using different methods to pull it. So we'll talk a little bit more about that careful process. And then visualization. We're big believers that visualizing the data more than just reading the numbers on the page, it really has, it's very impactful when you can see from a graph, a chart, bar graph in front of you, what the data is telling you about where to intervene is really helpful and more efficient as well. So in the data validation, an important part of this process, it's got to be checked and rechecked for accuracy, ensure that it's correct. Did you capture what you intended to capture? Make sure that the chain of custody, if you will, of the data purity is kept intact. Be careful that accuracy isn't lost through any manual or technical conversion processes, especially if there's manual data entry. Be careful of that. We really want to make sure we're validating that. And have multiple sets of eyes. You can get kind of snowblind looking at data sets, and we want another person being able to eyeball it, check for things like blank fields, et cetera, and then find and fix the source of inaccuracies. Let the team know what you found and validate again. Don't try some cover-up or some fudging if somehow something's hitting you as wrong. Fix it, because you'll end up paying for it later if you don't. So, Andrea, in Chenango, we did a lot of work in the report extraction and making sure that's done consistently. Can you share a little bit about what you've learned from that?
Well, the accuracy and consistency part has really been a big challenge for us, pulling reports out of Acumed. It can be a difficult system to use, and sometimes we're pulling inconsistent data from reports. And so one of the things, that's one of the big difficulties. The other big challenge has been we have had a high staff turnover. So we've had our Acumed reporting people leave the agency and kind of leave us high and dry without us really knowing how to do it, what they did, what were the metrics they used, what was the data they were pulling. So the two things that we've learned from this is, we have to document each report that we pull, make sure we're documenting, the same data point on each report and have that someplace that people can look back on. The second thing is that don't put all your eggs in one basket as far as training. Now we're really having to learn it all over again, but we're spreading the training out to more individuals so that we don't have to continue to reinvent these reports, and to ensure that that the data that we pull is actually valid and consistent. And as far as the CCSI part of it, because you've put our data into your programs, and that's really been helpful because it visualizes the data, by visualizing it, it brings it to life and it makes it more real and I think more usable for the leadership to be able to use that data to bring to their line, to the line staff.
Awesome, thank you. Yep, it's been a lot of work, but a lot of great progress has been made. I absolutely agree with you on that. So after validation, we want to establish the baseline and target. So we look at a period of time that's long enough to address the variability that can occur over time. So you want a long enough baseline to catch, well, did the weather change things, or was it summertime and the kids were in school, et cetera. So a long enough period of time that some of that evens out through the law of averages. And then we focus on the breadth of the measurement. Is it agency, program, job type, clinician, client specific? What is our focus? And it can be in multiple areas and should be. Then we create SMART goals, simple, measurable, achievable, realistic, time limited, just like we do with our clients. What is our goal for what we want to do with this data set? What will our next objective look like for improvement? And let's set that target. So just like we do with our clients, we set achievable targets. We want the feeling of success. Start with a win, start with an improvement, and have all of the baseline data and that what happens next with the data be ready to be visually shown back to your people. So establishing targets with input from stakeholders, you really want to know what is that reasonable expectation for improvement and what happened when you did that. So let's hear from everybody about what that target should be. Again, that's all about the buy-in, et cetera, too. So let me talk a little bit about going forth and doing the work. So enacting that PDSA cycle, staff are notified about the work group and its aims. So let's let everybody know what we're working on, how the data will be given back to them and disseminated. We have start dates and end dates. And then we have specific show rates that to go forth and do the work. So setting these targeted show rates at 75%. We introduced attendance improvement projects to the staff. We set up the CQI meetings, utilized administrative staff to help with client contact, sending letters, reminder calls, et cetera, care managers to engage, peer specialists to engage, and updates provided at each of the clinic meetings. So, Andrea, what has the data shown you so far about your efforts and what can be done to continue?
Well, the data, certainly the no-show data, showed that our interventions actually have improved our outcomes. by what I had studied this years ago, we had about a 65% show rate. And now with the interventions that we've put in place, appointment agreements as you talked about, we have a 75% show rate. So that was one big thing. Another is our intakes. We had sometimes 3, 4, 5 week wait to get somebody in from the time that they made their first call till we got them in to see. So that's when we implemented our open access process, and so we have no wait time virtually anymore, which that again impacts your no-show rate, because that's a whole group of class of services that you have virtually a zero no-show rate for. And which takes us kind of to our next process. What we want to implement is the just-in-time prescribing or just-in-time scheduling with our prescribers, because it has worked so well. We see that our prescribers have the highest no-show rate in the agency for the most valuable services, and we spend a whole lot of time and resources on writing scripts between appointments, and that's a loss of revenue, it's a loss of resources. So the data has showed us a lot of areas, and we're actually seeing real improvement and hopefully better outcomes for our clients ultimately.
Awesome, thank you. And we'll talk a little bit about how we visualize the data, what the data shows. You just did a great example of what the results have been from where we started, and getting prescriptions filled, et cetera. Better for clients, better not to chase people around and use up all that staff time, et cetera. So definitely enacting this cycle has led to a lot of improvements in that area. And interestingly, that for prescribers, your medical staff, really one of the most sought after services, often one of the hardest ones to get into from a supply and demand perspective. We don't have enough medical staff quite frequently, that having the highest no-show rates for that certainly needs to be addressed. So great example there. Some examples of now this is a basic visualization of we see what each clinician would see. So they would see their numbers for no-show failed, for canceled, and for attended appointments, and a visual breakdown. And also superimposed on this are what those ends are for each of those percentages. So you get a sense of not only how productive folks are, the number of visits they're doing, but what their show rates are. So this is just a snippet from Chenango, of course de-identified, so we don't need to know who these folks are, but the visual impact of this, it's kind of easy to see where you may want to intervene. So important to be able to visualize it. Then we also have what we see here is the, get it to go back there, trended data. So data over time. When we talked about establishing that baseline data, here we have show rate data for a program, up there pushing 75% or so. I'm not sure which, so again, this is de-identified, but showing cycles over time and having that visual impact. So being able to see it right in front of you allows you to really see where to intervene. And setting this up, it is about workflows, processes, and persistence in making sure this has gotten to energetically. So Andrea's talked about the open access example. So before, with workflows and processes, we had clients calling, they're sent an intake packet, it's returned and reviewed by the staff, insurance is checked, they're assigned at a team meeting, they're called back, the client registers for an appointment, insurance is again verified, then the clinical assessment occurs and they're admitted into treatment. All of this occurs at about a 4 to 6 to often 8 week wait. Now with open access, the client calls or just walks in, but they're directed right to the open access hours. Insurance is verified. They're told in that call, bring in your ID and your proof of insurance. The intake and screening information is done right then. The client registers. The assessment occurs and they're admitted into treatment according to regulations. So that is the new process. Notice how much cleaner, clearer, and effective it is. So looking at access too, and when we're looking at that, analysis of the data, we also see that we can see a very up and down approach with what we dealt with before. Sometimes people were getting in quickly, sometimes they weren't. So the point of this slide is we want it to be under more careful analysis as to what's happening there. So what are we doing with this new information? What are some of the options here? So talking about that workflow, do policies change to go along with it? Are we expanding PDSA to larger groups and departments from beyond the mental health clinic? Are we showing the results of those? And specific to this project, again, each clinician's getting their show rate data. There's expectations that are uniform across all of them regarding following up with clients. They're clarifying policy expectations, et cetera. The clinic brochure has been changed to talk about attendance expectations, and recognizing and congratulating staff on what we've learned from addressing high show rates, and again, as Andrea said, moving toward just-in-time scheduling for the medical staff. So it's a big process. Often we ask ourselves, are we there yet? There's so much work involved that it really can take the wind out of your sails if you're not careful. So it does require quite a bit of tenacity here. Here we have Vince Lombardi in one of my favorite quotes here. Obstacles are what we see when we take our eyes off of our goals. If we're focusing on what the mission is, what the end we have in mind, yes, there are going to be obstacles. We will encounter barriers. You can count on it. But it doesn't mean we quit, because there's always something we can do next to improve. So, Andrea, last question for you. How have you maintained your own level of energy, and how have you helped to keep staff motivated throughout this process?
Well, you know, the work that we do is so important, and all of our staff are interested in providing the best care they can. That's why they're in this business. So for me personally, what motivates me is seeing some positive outcomes from the things that we've implemented, seeing positive changes, improved efficiencies and whatnot. So that kind of helps keep me motivated to continue on, because it is never ending, the process of improvement. And for our clinical staff, I think that for them to see that the changes that we're making allow them to do the work that they love to do, and if it makes sense to them, then, you know, I think that helps them motivate them. And they want, as long as we can clear the way for them to be able to provide the work that they need to do, I think that's motivating for them.
Awesome, and great description of how it really is a systems effort, not something that just slides down to the direct care staff, but everybody's involved in the process. Very well described there. So there's a couple of tools we're providing you here. The CQI Workbook will be available to you. And what this is, it's an Excel workbook template for monitoring progress toward a topic. So it's set up with that Plan, Do, Study, Act approach in mind, very specific to the CQI process, identifies responsible people. So that's out there for you as a template to use to insert your own CQI processes into. Also, a quick self-check questionnaire. So 6 questions here on organizing your team, defining your value, your use of data, your action taken on that data, your ability to communicate around this. It would take you all of about a minute to do this survey. You can use it as a pre and a post. Just a very quick check-in terms of everything we've talked about today. How do you rate yourselves in terms of the robustness and effectiveness of your own CQI processes? So what do you do next?
All right. Dave and Andrea, thank you so much for the presentation today. We really appreciate your involvement and the words of wisdom from both of you. Andrea, it's so good to hear about what your experience has been like, what you've learned, and how you continue to move forward, and the energy of your team in wanting to really think about how to improve outcomes. So we really appreciate that perspective. For those of you that may be a little bit newer to this kind of work, we have some suggestions for how you get started. The first is to select an area of need or opportunity for improvement. You may know about something that you've always wished you could tackle and haven't felt like you know how to do it. Well, here's the chance. And once you've identified that opportunity, give some thought to what you're currently measuring related to that opportunity for improvement. And do you have reports that can drive practice improvement that will allow you to, as you make changes, be able to show that, yeah, your outcomes are improving, that that particular measure is moving in the direction that you want it to. Really beware of the discussions that can lead to more measurement without taking action on the data that you already have. You heard Dave say that today, Andrea say that, and Brianna has said that multiple times. Use what you have, begin there, and based upon doing some work with that, you may identify that there are some additional pieces of information that will be helpful, but don't anticipate without really digging in first with what you already have. You need to identify the stakeholders involved in practice improvement, and again, it shouldn't be simply done by leadership. For this to be successful, your staff needs to feel as though they're a part of it. And quite honestly, they have some great ideas because they're the ones that are doing the work and probably have reflected on some of the barriers in the past. Have some informal discussion with the staff about why improvement in this area is important. They're going to see it, but keep them involved because they clearly are the resource that's a part of the solution. Produce baseline data to guide the discussion. Know where you are and begin to think about how you're going to track to see where you're going to go. And finally, just get started. I think we pretty much end every presentation with that perspective. Just do one thing, and then that one thing will lead to another, and you'll be amazed at how much you accomplish. So thank you so much, again, Dave and Andrea, and again, everybody on the call, thanks for your participation. We want you to mark your calendars because the next webinar is on practice development and management. Okay, when you learn, you've measured, you've done some CQI, you learn you need to change your practice. You need to figure out how you want to do this differently. Here's the conversation that will help you formulate a plan for practice development and management that's taking place on May 23rd, 2018. And the in-person events that are taking place late in June. Again, the 4-hour events, we really want people to register individually, but bring your agency leadership team together, the team that's supporting this performance-driven academy work. You can see the dates. Albany, we're going to be there June 19th, Rochester, June 18th, and New York City, June 29th. And semester 2, where we begin to talk about finance and leadership development opportunities, those dates will be coming soon. So before we close out, we're really right at the end of the time. Okay, I've got one more webinar of interest to point out to you. I just want to check, do we have any questions?
We do have a couple questions.
But we're really out of time, so is it fair that we get back to them?
Yeah, we can definitely get back to them.
We have some questions, thank you very much. We will be getting back to you after the webinar ends because we really try to commit to our time, but we want to share with you an upcoming webinar of interest. The topic is evaluation of data collection that's taking place Friday, May 18th. It's a 1-hour webinar that's going to be brought to you by the Rochester Regional, or information shared by the Rochester Regional Behavioral Health Department. And again, it's part of our MCTAC initiative. These guys, you heard a little bit about their work during the last webinar, and I think people got so excited about what Rochester Regional Health was doing in terms of the evaluation of the data that they have, that they asked for a little bit more time. So again, we're pleased to offer that to you, and registration to that link you can find in your chat box. So again, we're a little bit after 1. Thank you so much for your participation. Again, thanks to Dave and Andrea for their words of wisdom, and hope everybody has a terrific afternoon.